minute, I will intimate you. Yes, we're live now, and with all your permission, we are starting. A very good evening and a warm welcome to one and all present here in this session. I am Debolina from Clinic. We are very much proud to be a part of this webinar as a digital partner. So now with all of you, I'm going to share a short glimpse of Clinic. Thank you so much all for your patience. Our website goes www.clinic.com. You all are invited to visit our website. Clinic is India's largest live digital CME and doctors generated medical content platform, which is exclusively free for all the medical practitioners. So now without further delay, I'd like to welcome Dr. Nihal Patel ma'am to take over from here and start with our today's program. Over to you, ma'am.
Thank you, Debolina. And I welcome all of you, all the PGs, to this great teaching program. I thank AOPG Gujarat, AOP Gujarat, President Dr. Rakesh Desai and Dr. Kirit Sisodia for continuing this program. I welcome Dr. Baldev Prajapati sir, who is convener in this program and a great guide to all the PG students. Today we have a case on hematology, and we have two experts which are eminent in their own field. So I welcome Dr. Mukesh Dhankar sir, who is professor. He is at Lady Hardinge Medical College in New Delhi, and he is DM in Pediatric Hematology and Oncology. I welcome Dr. Sheetal Kulkarni. She is a practicing hematologist-oncologist at Pediatric Hemato-oncologist at Surat, and she completed her MD in Pediatrics with gold medal in GMCS in 2015. Her major interests are hemoglobinopathies like thalassemia and sickle cell with acute leukemia and lymphoma. We have Bhargav as the presenter, and he is joined with other students to have a backup with him. We have Dr. Sheila Iyer Madam as his mentor. Ma'am is professor and head at SSG Hospital and the Government Medical College, Baroda. I welcome you all, and I give this platform to Baldev Prajapati sir. So please.
Good evening, friends. Welcome to this our regular Saturday PG clinic. Today, as Dr. Nehal said, that Dr. Bhargav from Baroda Medical College is the presenter, and he has selected the case from the hematology. We are very two eminent pediatric hematologists, so definitely when we are discussing their inputs will be very valuable in our learning. You know that we are discussing mainly keeping in mind the postgraduates, MD Pediatrics and DNB students. And I'm sure that starting from that basic understanding to the new development in this particular topic, the hematology, will help us a lot in our learning. And I request all these students, those who are on the screen, please keep your video on, give even your identity so that all of us become familiar with each other and we can have the very good interactive sessions. You know that unless we participate, unless we speak something, nobody can learn. So please keep in mind that mistakes are always possible with everybody. So we should not be reluctant or hesitant to ask the question or to put our comment, or even you may not agree with these your teachers. That's, I will say, good learning session for all of us. With this remark, you know that the flow of the chart, Dr. Bhargav must be aware that first he will, because you know that compared to the classroom discussion, this should be a little bit different. Dr. Bhargav will share his PPT with this history part first, and from the history we'll take the point of the discussion. At the end of history, at least we should have some provisional thought process that what is the likely problem with the child. With examination probably will be more clear. We can have the clear at least clinical diagnosis. And at the end of the investigations, probably something new to confirm or our to surprise even maybe the different diagnosis. So I'm sure that this type of flow process will help us a lot, particularly with the presenter. I request the students to participate very actively, and with that we'll take this even expert opinion of the experts, and everybody is free, I will say, to speak at any time without any hesitation, even including these students, faculties, experts, everybody. With that remark, I request Bhargav to share his PPT and start the history part. So Bhargav, please.
Okay, sir. Good evening to all the teachers.
Bhargav, can you make it full screen? Is it full screen?
Yes, sir.
Okay.
Can we start, sir?
Yes, yes.
Good evening to all the respected teachers. Myself, Bhargav Patel, second-year resident from Baroda Medical College. I am presenting a case on pancytopenia with failure to thrive in a young infant under guidance of Dr. Sheila ma'am, Dr. Divya ma'am, and Dr. Asruti ma'am. Coming towards the chief complaint, I am presenting a case of a 3-month-old female child who was brought to our emergency with complaints of fever since 3 days, vomiting since 3 days, and complaint of excessive sleepiness since 2 days. The fever,
Okay, carry on.
The fever, which was acute in onset, low grade in nature, and relieved by medication. The vomiting was 3 days ago, acute in onset, non-projectile, and containing milk. The child was also having complaint of excessive sleepiness since 2 days. There was no history of refusal to feed, passing loose stool, cough and cold, or excessive crying. For the same complaints, the child has been taken to nearby private hospital, and on investigation and examination, child was found to have severe anemia with hepatosplenomegaly and referred to tertiary care center for further management. Past history of the patient is not significant. Birth history.
Dr. Bhargav, just can you stop sharing for a while? I think before you provide the more information.
Okay.
Okay, all of us know that already he has revealed so much things. Never give the title even to your case in clinical discussion. That is very important, right? And second, even suppose previous consultant has whatever they put his impression, that also you can keep at last. Not necessarily that what his impression may be right, may be misguiding you, and it happens. And therefore, in the practice, it is always important that go through the history without, I would say, added information from other your colleagues. That will give the independent thinking, and that helps a lot. I will say, and at the same time, same thing happens in the exam also. The examiner is not interested that what is the problem or diagnosis or so. Examiner is interested that what you are thinking. And for that reason, let us start, I will say, from the first slide. You are sitting in the OPD. I think that is very common scenario. Mother enters your room and she complains, as you said, that the 3-month-old child, female child, having the complaint of fever, vomiting, and excessive sleepiness. I think what will be your thought process? Always it is said in the medicine, in the history, your thought should be the action from the very first complaint. Then probably as you get more information, your thought process may be getting changed, maybe narrowed down, and probably you can go for further confirmation with detailed information and examination. So suppose just simply from 3 complaints, and who are the other post-graduates? Please give your identity so that I can understand. Dr. Bhargav, I think you can introduce our colleagues because they are probably shy and therefore remaining away, at least from their video. Please keep your video on, those who are on the screen. By keeping the video on, it feels the feeling that we are in the classroom. Otherwise, we feel that it is just on. Yes. Bhargav, I think you will have to give the introduction of your colleagues, just so that I can be familiar, and I'm sure that other teachers also can be familiar.
Yes, sir.
Or suppose if they themselves give the introduction, that is very good. Please. I wish that self-introduction is good. I think
Good
once,
evening.
yes, yes.
Good evening. Sir, I'm Dr. Mukesh Dhankar from Radiology.
Yes. You know, teacher is starting that this is the way. Dr. Mukesh is encouraging us. I know him. He is pediatric hematologist at Lady Hardy Medical College. We are going to learn many things from him today. Now, others, I request other students to give. I know Ivan Ashruti. She is also faculty from probably SSG Medical College. I know since her, I will say, postgraduate days.
I am Dr. Divya Dave, Associate Professor in Paediatrics
Okay, madam. Welcome.
at Baroda Medical College.
Yes, yes. Thank you.
Very good evening to all. My name is Sheetal. I'm from Surat and I'm a practicing pediatric hematologist here at Surat. Thank you.
Thank you, madam. I think already you were introduced by Dr. Nehal. Dr. Sheetal is from Surat and she's pediatric hematologist. Dr. Mukesh is also pediatric hematologist. They are going to help us in our further learning. Dr. Kishan? Kishan, you are not audible. You are not audible. Kishan, again you are muted. Unmute yourself, please.
Am I audible, sir?
Yes, yes, very well. Please.
Good evening, all of you. Myself, Dr. Kishan Patel, third year resident doctor, SSG Hospital, Department of Paediatrics, sir.
Oh, I think third year resident is as good as the expert in the field. Good. Please, I think you should participate very actively. Yes, Dr. Srushti?
Good evening, sir. I'm Dr. Shrishti, final year postgraduate, SDM Dharwad, sir.
Dharwad, oh.
Yes.
I think last year our colleague presented the case at Tuesday PG Clinic.
Yes, sir. Yes, sir.
Yeah. So I think it's a good to see all the students. Dr. Dailya? Dailya, unmute yourself, please. You are muted.
Good evening, sir. Myself, Dr. Lokesh, third year resident from Department of Pediatrics, SSG.
Okay. So Dr. Lokesh, Dr. Srushti, Dr. Kishan, I think Lokesh again has some other, I think platform he has joined. Dr. Madam Shaila Iyer is seen now on the screen. All of you know her. She is head of the department at Baroda Medical College. Already, Madam, you were introduced by Dr. Nehal, just for the sake of formality, but I think all these students, all the faculties know you very well. And she is a very good teacher. I think students are really most fortunate, those who are getting the opportunity to learn the pediatrics under her. Why I'm actually making some platform or this, I will say warming, the students should not hesitate to participate actively. Please, mistakes are going to be there even with the experts also, with anybody in our science. So on the contrary, please positively make the mistakes on this platform while discussing. What was my question that Dr. Bhargav has already provided the preliminary information. I think it is very routine in our pediatric OPD that we are sitting and mother enters with the complaint that 3-month-old girl had fever, vomiting, excessive sleepiness since 3 days. Kishan, suppose the child is brought to you, what will be your thought process? With the fever, with the vomiting, and excessive sleepiness in 3-month-old child. Please unmute yourself. Yes.
Sir, it might be associated with some septicemia and maybe acute gastroenteritis.
Right.
Or other surgical conditions.
Please always keep in mind the common conditions first. right? What usually we are getting in our OPD. Very rightly you said, 3 months old child complained with fever, likely some infection, right? Then vomiting, maybe the part of toxemia or something to the child, or maybe some GI problem. But excessive sleepiness, who will take this analysis of the excessive sleepiness in 3 months old child? Dr. Srishti, can you take it? Yes, unmute yourself. Yes, please go ahead.
The excessive sleepiness is either because of child being anemic first thing,
Okay.
or poor feeding, or feeding pattern is not right.
Right.
Or,
Anybody else want to add something? She has
Maybe
started. Yes.
It may be associated with the hypoglycemia.
Yes, absolutely right. That is more common in 3 months old child, that too. It is as good as the newborn. So I think and number one, excessive sleepiness. Suppose your mother is calling you on phone. In 3 months old child, we cannot answer on phone. We'll have to see the patient. What I mean to say, it's a worrisome complaint, right? It's a serious problem. We cannot take it lightly. And that to 3 months old child. And very first, definitely, the thing should come to your mind to the hypoglycemia. Dr. Yogeshwar, can you mute yourself? Dr. Yogeshwar, please. Yes, thank you. Thank you. And second, suppose with some fever, then 3 months old child, some severe sepsis. And child can go for the excessive sleepiness due to the even CNS involvement, right? So maybe the simple hypoglycemia, maybe some infection, and infection is severe or serious, I will say, with the sleepiness, bacterial infection, maybe the sepsis, maybe the meningitis, right? Of course, as Dr. Shushti said, maybe the anemia also. We do not know the cause. But then for anemia, what, Shushti, suppose if it is anemia, what cause you will keep in mind with this presentation, fever and vomiting? Suppose the apparently looks quite pale child, it is severe anemia.
So
but
then for the birth history, whether it was preterm or
I think the mother says it's a very short history of fever of 3 days only. Otherwise, baby was very well.
so viral cause should be considered first, sir.
Which infection will cause a severe anemia? Because any fever is a very prominent complaint. An apparently quite pale child. What thing should come to your mind first?
Malaria.
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 Absolutely.
Malaria.
Malaria will cause it based on a fever and apparently looking pale child. Malaria should come to your mind first. And so 3 days, and malaria is not uncommon. Fortunately, since last few years, it had decreased. But at the same time, I will say we do come across, and with the excessive sleepiness, severe anemia and fever, maybe the falciparum or the complicated malaria by definition, by WHO definition, it's a complicated malaria. You cannot take it lightly. Any other reason for fever, vomiting, excessive sleepiness?
Acute gastroenteritis.
Okay, but I think, gastroenteritis is not so common in the children. Most of the time they are breast, and really it is not gastroenteritis. Always keep in mind the sepsis. Any younger the baby, usually they don't have the localized infections. They have the sepsis. Suppose pneumonia, then also part of sepsis. Gastroenteritis is part of sepsis. So I think, because the younger the baby, they are not able to localize the infections. Of course, 3 months even occasionally you may keep in mind, but I think the apparently thought process should be like this. So I think we are anything else. I think experts, those who want to add something more, even some teachers, Madam Dr. Shailaben or Ashruti or even experts can, whatever, suppose if you want to add something.
Yeah, sir, I think probably you covered, but basically a child with fever, excessive sleepiness or lethargy, if we go even by our IMNCI classification, lethargy, fever, and this definitely falls in the red zone or a acutely ill or a sick child. And one of the commonest that one would think is definitely a septicemia, as you covered. Malaria, agreed, but of late, malaria has become quite less as compared to other vector-borne infection. And again, just being a 3-month-old child, unless until we get something in history, yes, it would remain as a part of investigation, but may not come as a #1 diagnosis these days.
But in this area, please don't forget it. Just if I remind you, last week only, I had 6 months old child, severe pallor anemia, and peripheral smear showed the falciparum. So
we have seen congenital malaria also so much. So we
definitely it has come down. Fortunately, come down. But we should know that it's not totally out. And maybe the problem. But yes, of course, that fortunately it is less since last few years. So I think what Madam gave the idea, I think that is very important. Try to follow methodologically. IMC program, why they have devised methodologically thought process that acute severe sickness, you can locate some common causes. And I think from that idea, that even in one sentence, if you want to answer, that it's basically severe sickness or illness with the child. And that illness can be in any form. Can be the sepsis, can be the even metabolic derangement, can be some hematological condition. Even just we are keeping the common condition, but uncommon conditions, hematological conditions are also possible that may present in this way, which we can keep in mind.
As Srishti put it, that if because he had already disclosed a severely anemic child would present with quite a lethargy and poor feeding or not active, having much of activity. Yes, that also can explain.
Anything else, or should we go further in the history?
I think we could go further.
Yeah, Bhargav, you can share the PPT.
One more differential diagnosis, pallor, lethargy in young infant, it can be ICH also.
Yeah.
Yes.
Very
only thing probably convulsion or this has not come, but ICH and anemia again are an important cause.
Very, very rightly Dr. Ashwati mentioned, and in that, you should ask the history of vitamin K. Many times it is missed.
Yes.
And then, late
home delivery and not available given.
And late hemorrhagic disease of newborn can present with intracranial bleed. And therefore, excessive sleepiness and pallor may be the presentation. Of course, what Madam said, commonly seizures, but I think seizures may come later on. So I think that's very valid point, I will say, which we should keep in mind. Of course, even dengue is not common, I will say so, but even dengue can also present in the young babies in this way. That we should keep in mind. Okay. I think Dr. Bhargav, you can share your PPT and go for further the history part. I think for the postgraduate, please, in the exam, nobody is interested in the diagnosis. How you are thinking for the fever, how you are thinking for the lethargy, how you are thinking for the hypoglycemia or pallor or whatever the symptom. And I think in the practice daily, we have to do like that.
At this point, I would just probably, one of the residents said surgical condition, but the detailed history of vomiting will better give idea about whether it could be surgical or not.
Yes.
Birth history. The child is full term. Birth weight was not known. Home delivered. Cried immediately after birth with history of no NICU stay. Coming towards the family history, the mother had history of blood transfusion a year back. Child was born out of non-consanguineous marriage. Younger sibling. Elder child is normal. Birth vaccination was completed. Developmentally, child has attained partial neck holding, hands partially closed, and social smile not attained. Moving towards the anthropometry portion, the child was 2.75 kg weight on receiving against the expected weight of 5.4 kg, which was falling less than third SD, less than -3 SD. The head circumference was 34 centimeter against the expected of 40 centimeter, which was again falling less than -3 SD. And the length of the child was 53 centimeter against the expected length of 60.2 centimeter, which is also falling under less than -3 standard deviation. So here I have put the weight of the child on the weight for age WHO Z-score chart, which is showing the weight is falling less than -3rd standard deviation. Length is also falling lesser than the -3 standard deviation, and head circumference is also falling less than -3 standard deviation. On examination part,
I think can you just stop sharing? Just stop sharing. I think always please keep in mind for the postgraduate in the exam. The first, I will say, as you know, the KBC, there are some slabs that the 10,000, then this some 3,20,000 like slab. So in the postgraduate also, the first slab is this, or I would say first station is the history. Only from the history you should have the provisional diagnosis. And Dr. Bhargav, this anthropometry should be included in examination, not in the history. Right? In the history, only the narration, only the description, only the information, and the analysis of the information. Right? Anyway, I think whatever the information he has provided, any further discussion, I think what even Dr. Ashwati was telling, the similar situation is there in the history because it was the home delivery. And I am sure that vitamin K, the question mark. Dr. Bhargav, did you ask me whether vitamin K was given later on?
Sir, it was home delivered child, and by the time XO108 was came, and the child was taken to the nearby primary health center immediately, and from where the child was given initial management, in which the vitamin K was given, and also birth vaccination were.
There's your presumption, or it is confirmed that vitamin K was given?
It is my assumption, sir.
Yeah, because this is very important. And no, you have mentioned only birth vaccines, but child is 3 months old child. Whether 1.5, 2.5 months given or not?
No, sir.
So what was the reason for not giving these vaccines?
Basically, my child is from tribal area, and he is belonging to the lower socioeconomic class, and the parents are being farmers and working as a laborer at some other place. So they were not routinely followed up in the on nearby Anganwadi or nearby primary health centers.
Whether they were advised or not. Dr. Bhargav, you know, now the network of health in the country as a whole, and particularly in the state of Gujarat. You said that as after the delivery, immediately 108 was available.
Yes, sir.
Child was taken to some at least primary center where this at least healthcare was possible. And then I'm sure that that means they must be nearby that center. They must have advice regarding the vaccines also. So I think you should go in the details that what was the real reason for not vaccinated this child. Okay. I think this is, and you know, in the exam also, suppose any child is not vaccinated, not I will say the exam in your daily practice, best ways to go in the details. Why this particular child has not received the vaccine. I think non-availability of the facility is now this not, I will say, common situation. Occasionally maybe, but not the common. Most of even the smallest places, and you must be watching even on television and other places, that the Anganwadi our services is so much that they are going at home, they are talking to the parents regarding even that expectant or lady or even the lactating mothers. So I think this we should go in the details. Anyway.
I think most probably knowing it is they did not make any effort directly because that is what is even looking at the anthropometry, the child has never gone to any kind of health facility and records not being available. So definitely not really well monitored, or they have made any use of health services.
Yes, they are not.
The ASHA or health worker has reached them.
Probably they are not utilized. You are right. Anyway. Anything else? And any students wants to ask the question to Bhargav? Any more information?
Yes.
Any more clarification? I think that you should do. And I expect from the students first. On the contrary, you should bombard the question to your colleague.
I know here he does not have much of data, but otherwise he put it as that past history, nothing significant, no NICU stay. And probably the baby has not visited any health facility. But otherwise, what more could have asked for in history itself? He gave one history that there is a mother received transfusion.
Yeah, I was coming to that point. That question should come to your mind. That was the indication. Dr. Sushti, would you like to go that point for the details? That mother was given the one blood transfusion just 1 year back.
So before probably she conceived the baby.
Baby.
I think
not during the gestation because it's 1 year back.
You should ask these questions to Bhargav. Bhargav must have gone in the details of the history.
I would like to know about the maternal. How was her ANC, sir? Like ANC, was it significant with any infection, or she received any? Did she receive the iron folic properly during her course of pregnancy?
I think, Sushti, here if you take the point of the transfusion to the mother, what Madam said is exactly right. That probably this is before the conception, because now the child is 9 months, 3 months old. 9 months if you consider the pregnancy. That means almost if the time comes, it's absolutely that time that before the conception probably she received the transfusion. And that one should go in the details that what was the indication for the transfusion in this mother. That probably will help you for further even the thought process, or at least you can correlate that is there any importance of the point of giving the transfusion to the mother and the present illness of the baby, whether in any way it is related or it has nothing to do with. But exactly what was the indication for the transfusion in the mother? Very, very important point. Dr. Bhargav, can you take it in details?
Yes,
I hope that
yes.
you must have gone details.
Yes. As per mother, the mother was having one blood transfusion before conception, and she has not visited antenatally any health facilities, but after rest details are not available as per mother, but she is giving history that before conception she has visited single time ANC care, and after which she has received one PCV transfusion, sir. Folic acid and iron tablet.
So transfusion was given after the conception?
Before the conception, sir.
So what was the indication? That's the point which we want. I hope that you have gone into the details, and even simple mother can also answer you that what was the indication for the blood transfusion. Whether was she had having the bleeding, whether was there any reason for the anemia, whether this is the only first transfusion or in the past also the mother received this transfusion. But all the points are very, very important for us to know.
This was the first blood transfusion to the mother. Yes, sir. And she has not given history of any repeated blood transfusion.
Okay.
And
no any problem of active bleeding also.
Investigations were not available to get details of it. It was just a random history given. Again, a tribal area, we wanted if she had a screening report or anything, but unfortunately wasn't available.
Okay. But you know, simply if you ask the mother will say that the person who transfused at least must have talked to her that you are having severe pallor, severe anemia or bleeding or something, right? And that will give you the idea. Anyway, at least we presume over here there must be the probably severe anemia, and that with the transfusion, how much indicated or not, probably we don't have the exact answer, right? But suppose really there is some multiple transfusions in the mother, suppose in some other case, what will be your thought process? Dr. Kishan, suppose in some other case you are getting the history that mother was given randomly at some time the transfusion 2-3 times in the past. What reasons will come to your mind?
Sir, maybe hemoglobinopathies like thalassemia or sickle cell anemia, if mother is tribal area or sickle belt, coming from the sickle belt. So history of blood transfusion, multiple transfusion.
What are the indications for the transfusion in sickle? Whether it is regularly as we are giving the thalassemia?
No, sir. Indications for transfusion or during crisis, sir, sickle crisis.
Okay, and that I think if you ask the details, any person must be knowing, right?
Yes, sir.
Anything else? Okay, hemoglobin. Do you think the thalassemia in this even the lady who reached to this and suppose thalassemia, which type of the thalassemia? Suppose thalassemia, and mother is a naturally young lady, and she has given some transfusion, suppose in the past, not regular transfusion, and suppose by chance it is thalassemia. And which type of the thalassemia can be there?
Thalassemia minor, sir. 2 or 3 transfusion till now.
I hope that Dr. Mukesh is there. Dr. Mukesh, are you available? Sir, can you just take this point? I think may not be related to our case, but suppose in some other case, I think not an uncommon story in our practice that randomly some transfusions are required even the lady in the past, and suppose by chance if it is thalassemia, what can be the variety just for our learning point of view? Can you elaborate that point?
Right, sir, surely. So basically, to answer that, I would like to define a few things prior to that. So when we say a transfusion-dependent thalassemia, we try to cover a spectrum of hemoglobinopathy, which could be hemoglobinopathy involving globulin chains, practically. So it could be alpha thalassemia, it could be beta thalassemia, it could be sickle, it could be HVE, it could be HVS, it could be HB Punjab. So it's a spectrum of disorder in which the transfusion is essential for the survival of the patient. So we start transfusion in any of these things when the HB is below 7, measured on 2 occasions, 2 weeks apart, 1, or there is severe wasting stunting, that means anthropometry is not up to the mark, or there is severe hepatosplenomegaly, hemolytic phases, or some fracture. So that is a thing when we label it as transfusion dependent. But the other is non-transfusion thalassemia. That is again would be covering the similar globulin chains disorders, but there the transfusion would be required episodically or occasionally, usually when the child is sick or when there is some stress. But this non-transfusion dependent thalassemia term is only for that point. The child who is non-transfusion right now may be later on become a transfusion dependent depending on the conditions which I had mentioned. So this is the thing. All these transfusion needs are clinical decisions. They are not based on laboratory decisions. They are not lab-based decisions. For example, if we have an HbF of 99, for example, but the child is not requiring transfusion, that means that child is a non-transfusion dependent, not a, in spite of being major, he is non-transfusion dependent, then he is non-transfusion dependent. We will not give transfusion unless he meets those of the criteria which I mentioned. The reason for that is there are many modifiers. There could be primary modifiers, secondary modifiers, tertiary modifiers. So there could be modifiers which are ultimately affecting the clinical outcome of the child. So it's a clinical decision. It's a spectrum of all globulin chain disorders, not just beta thalassemia. It could be anything. I hope I can answer that.
Yes. I think this is the point which I wanted with the students. Now I think in thalassemia also we have to mainly categorize. It's a transfusion dependent or transfusion non dependent. You know, the broadly need to categorize as a whole all this spectrum of these hemolytic anemias, and then you can go at least in the details. And as I was talking, that suppose these are the stories there in the mother, you would like to go in the details that if at all it is really this sporadically or randomly occasionally required this transfusion, that means it is not a transfusion dependent condition, some other variety, and that you should go in the details, and then you can try to correlate whether the same is possible in this present case or not. So I think that's the point which just I wanted to sensitize you that we should go in the details of the mother or maternal information, or I will say some other family members information also. Okay, I think Dr. Mukesh, anything would you like to add in this history part?
Right, sir. Once the child is having fever, vomiting, and excessive sleepiness, I would definitely like to ask whether there is a history of any progressive pallor or sudden onset of pallor. That is very important. I would like to ask about any bleeding manifestations, which is very important. I would like to ask about any recurrent past infections and specifically any serious infections meriting some admission for the child. In addition to that, I would also like to ask about the history of any jaundice since birth, persisting or intermittent. These are the few things which I would like to ask. And any history of transfusion also, sir. Sorry, any history of transfusion also.
I think
you can answer all these questions.
Yes, sir. There was no past history of any admission or any kind of OPD based medication also, sir. So there was no history of yellowish discoloration or anything, sir. And the child has not visited or being sick before this admission, sir.
Okay. But Dr. Bhargav, whether the mother complained of the pallor at any time?
No, sir.
Actually, thing has happened is in this tribal mother, the reason whether it has been there or she has not been able to recognize it.
Yeah,
really. Just visited when child became ill, has visited a nearby health facility and then was acutely very, very sick child got transferred. So all the questions that asked by Dr. Mukesh are very, very relevant, agreed, because one would know whether this is a from neonatal period onwards, slow hemolysis and now coming as acute, severe anemia or an acute bleed or recurrent bleed and coming as anemia. And from history, none of those things were really, really evident. Probably parents visited the health facility for the first time. They're not even gone for immunization.
Anyway, I think this is something unusual. Otherwise, you know, that pallor is attention drawing and any mother will complain of the pallor. That's not uncommon, I will say. On the contrary, we have not asked even the mother will complain. And then what sir said, Dr. Mukesh, that you can ask with the progressive and duration and everything. Will
an acute.
But suppose for a minute even, consider the story of the fever and the pallor and even the sleepiness and like this. Any postcard you can take it with this information that what are the common conditions will come to your mind. Suppose now we have restricted that probability with the severe anemia. Initially we were considering that maybe the sepsis, maybe the malaria, maybe the hypoglycemia. I think suppose gradually if we narrow down that this is due to the severe anemia and the patient has presented with this fever and even the vomiting and even sleepiness, and child is 3 months old. So what conditions are coming to your mind which are even the differentials which you can consider in this baby? Who will take it? And I'm sure that these are the question is going to be asked in their MD examination. Any child, we are not talking of this patient. Suppose any child presents at 3 months with severe anemia, fever and even this vomiting, then which conditions will come to your mind? Or which conditions can present in this way? Who will take it? I think postgraduate should come forward.
Yes.
Because you know, here in the exam only you have to answer. Here anybody can answer and it will do, but in the exam it will not do. You have to answer. So I think, should I ask Dr. Yash?
Where is he?
Good evening, sir.
Yes, yes. Good evening.
Sir, first thing will come in my mind is, sir, fever with lethargy and sudden onset pallor. There may be a possibility of intracranial hemorrhage is there, sir.
Okay.
And patient is lethargic, also and having complaining of vomiting, sir.
What is the reason for the intracranial hemorrhage which you are thinking? What is the likely etiology?
Sorry, sir.
What is the likely etiology, suppose for intracranial hemorrhage which you are thinking?
Sir, first possibility may be due to a late presentation of hemolytic diseases of newborn. Due to
hemorrhagic disease of newborn. Okay.
Yes.
Okay, I think
due to
And if
vitamin
it
D
is,
deficiency.
yes, we consider that is number one. Anything else?
Trauma.
Another possibility is trauma, sir.
Trauma.
Absolutely good.
But
there may be some history of fall and trauma.
Yes.
Okay. Suppose now if I provide the more information that vitamin K was given,
Yes, sir.
and there is no intracranial hemorrhage, or there is no even the history of trauma, or in simply if I even answer that there is no evidence of intracranial hemorrhage, then what are the other reasons?
So maybe there is blood losses from GI tract is there.
And what can be the which condition?
Patient having this.
I think Dr. Yash, if I remind you, 3 months old child develops suppose GI tract bleeding, that will be the hematemesis first, then the pallor.
Oh.
Pallor will come, but later on. The first, the hematemesis, obviously this vomiting will be there with the blood containing. That will be the first complaint from the mother.
Another thing would be probably if we are thinking that microscopic losses through blood and over a period the child has developed anemia, then one has to think of reasons. This is a breastfed child.
Yes.
If this was a child who was being top fed, was having recurrent diarrhea and failure to thrive, then what could have been the cause for anemia?
There may be a protein allergy, ma'am.
Yeah, so there could be microscopic blood loss which could have been occurring and the child could present with anemia.
Yes.
Then Dr. Mukesh sir also asked about neonatal jaundice, a prolonged jaundice. Does it anyway give you a clue that the child could now come with a severe pallor?
Late manifestation of ABO and RH incompatibility.
Yes, that can also, that ongoing hemolysis continues to give you anemia and then present can. Then was it acute pallor also was asked? Other than hemorrhage, what can cause acute pallor?
Please keep in mind, in any hemolytic process, the chief complaint will be the jaundice. Pallor will be the associated complaint. And that's why when the multiple complaints, always try to locate the chief complaint. You know that RHBO, what is the main complaint if you're senior patients? Jaundice.
Jaundice.
Of course, anemia is there, but it is associated. And therefore, there are the multiple complaints decide the chief complaint. Chief complaint will help you a lot. On the contrary, can you think some other congenital conditions?
Yes, sir.
Yes, sir.
Patient having microcephaly, I am suspecting torch infection is also there.
Okay.
Persistent pallor is there, microcephaly is there.
Again, what I will say, you know, the anemia can be in several conditions. But the conditions where the child has become the sleepiness, child has become even the fever, that means some secondary infection is also possible. Right? So try to think the conditions in a 3-month-old child which causes severe anemia. To that extent, the child has become the sleepiness, and it is a part of probably severe anemia. Any congenital condition? Suppose any condition related to the bone marrow?
Aplastic anemia.
Aplastic is not common in this 3-month-old child.
No.
But some, I will say, cousin of this congenital aplastic, where only the RBC series are affected. Only anemia.
Red. Your red cell is there.
Yeah, pure red cell can present in this way. Diamond black plan can, this is the age of the child, 3-month-old child. 3-month-old child will present with severe anemia. And there is prone to develop the infection, and therefore now the fever can be the problem. Right? It can present in this way. So anything else? Now further. Suppose if it is diamond black fan, yes, you can keep in mind.
Yes.
If it is not diamond black fan, any other condition which causes the severe anemia, or I think what Bhargav was given the title, pancytopenia, anyone the infection. Any condition which you are able to think, even which can cause the blindness of the child. I have seen the child with the blindness, 3 months old, 6 months old child. And even the severe sepsis are also known in these patients, and pancytopenia. Anybody? Srishti, any point comes to your mind? I'm giving this scenario, I'm giving some hints. And I will say, yes, these type of patients are seen, not uncommon. And suppose that due to some reason, X-ray was taken, which helped me for the diagnosis. X-ray was taken by previous pediatrician for pneumonia. But that X-ray helped me for the diagnosis. It was obvious. From the X-ray diagnosis, it was obvious. I will wait for some time because I want the answer from the students. And in the exam, you will have to respond because these are the questions are going to come.
Disseminated tuberculosis.
Disseminated tuberculosis, you know that Srishti will not cause this type of the picture. Here,
again, this child is just 3 months. I mean,
Yes, ma'am.
congenital tuberculosis, a different thing, but not the. Sir is telling X-ray. Take that hint.
That X-ray has taken a very classical picture that from distance anybody can say, yes, this is the condition. It's related to the I would say, skeletal condition.
Congenital syphilis.
No.
It is not the infection.
Anemia, failure to thrive.
And later on I got that the hepatosplenomegaly is also there.
Yes.
And the child is prone to develop sepsis. Even there was narrowing of the foramen, and that's why the child was having the blindness also. And it's a bone condition.
Osteopetrosis.
Osteopetrosis. Any osteopetrosis can present in this way. And this is the age also.
Sir, we also did a X-ray for osteopetrosis.
Yeah.
That was also one of our differential diagnosis. And
Okay. Yeah. Dr. Ashwati, just I am giving the broad thought process. In this case, it is thought or not, I think different situation. But exactly, that means but Dr. Ashwati said that they thought of. That's good.
It's a 3-month-old child, hepatomegaly, anemia.
That means this differential was there in their mind, and it should be there. Even it is, I would say, it is expected from the students also in the exam. So I think these are some conditions. Dr. Sheetal, can you take that 3-month-old child present with severe anemia and just only this history? What other differentials, suppose if you are missing something, you can add, please. Please unmute yourself.
Yes, sir. So other thing I would like to add is to know if other systems are involved. So for example, if patient is having hematuria, so maybe I can suspect upon conditions like neuroblastoma can also have fever, can present with fever, infection-like features, and can present with hematuria. Or if patient has any skin lesions. So for example, LCH, Langerhans cell histiocytosis. A very young infant can present with chronic skin infection, which can look like fungal infection but cannot be. So maybe that child can also present like this. Or very rarely parvovirus 19, congenital parvovirus 19.
Exactly.
If we say mother has got a hemoglobinopathy earlier, if we say maybe she is a thal minor with iron deficiency anemia or thal intermedia, maybe she is harboring parvovirus 19 and this child has got congenital parvo B19. So maybe slowly by 3rd month the patient must have developed severe anemia. So this
absolutely. And I think even you can keep it the leukemia also rare, but I think Dr. Sheetal must have seen.
Yeah.
Being general pediatrician,
definitely we had kept in mind later in the process, not in the first. But then
so I think these are the points which are expected from the postgraduates in the exam. That with this type of scenario, what are the differentials? Which probably you can start from the simple to malaria, even to suppose some infection, sepsis, to even the suppose related to either the erythroid series or pancytopenia. You can take all the differentials starting from diamond black palm, even the osteopetrosis, to even the parvovirus infection, to even this rare but leukemia also you can take it and it can present. Even as Madam said, Dr. Sheetal, even histiocytosis, not so common at this age, but yes, but it has been even reported. So I think these are the things which we
One more thing I would like to add, nutritional. Because mother's nutritional status, she received transfusion, then the child has not thrived well. And what we've been seeing is B12 coming early with this. So
Absolutely.
that also should, because on examination also is going to come out with finding, but then nutrition does in our country remain an important cause of anemia, even
And
in young age.
severe malnourished mother, an anemic mother, particularly with the B12 deficiency, and her offspring, they can present with the pancytopenia also. The cause may be the megaloblastic anemia, but they present with the pancytopenia. So I think these are the picture. Probably age is little bit early, but still probably in our setup, we do come across younger babies also.
We have been seen.
So I think these are the things which we can keep in mind. Now I think should we go examination or anybody wants to add something? I think good interactions from all the sets, I will say, from students to, of course, the faculties and expert. They added a lot in our understanding. So now, Dr. Bhargav, you can share your PPT and start this examination.
Just remind everybody with your anthropometry on the examination. Okay, and then go ahead.
On examination,
I think you can say that the child really had failure to thrive like picture because child's measurements were like a newborn, though child was 3 months old. And there was no history of being a preterm. We do not know exactly the birth weight, but the current status of the child was much, much below the expected standards.
Yes. On general examination, the child was having severe pallor with knuckle pigmentation and the child was lethargic. There was no icterus, no apparent dysmorphism, no rashes, no petechiae or ecchymosis, and no evidence of any lymphadenopathy. Vitally, the child was stable but having temperature of 99.4 degree Fahrenheit. On systemic examination, my child was having on perabdominal findings, the abdomen was soft, non-tender, liver was 3 centimeter palpable in subcostal region, which was soft in consistency, having smooth surface and rounded edge, and spleen was just palpable. Other systemic examinations were not.
So the important findings, you had severe pallor and significant pigmentation.
I think you can stop sharing.
Okay, sir.
Investigations will go later on. Please, from the history nowadays in the DNB or MB examination, some examiners may ask in this way, that what you are expecting on examination of the child before you examine. I think already he has given the findings, but this question may be the common now. That means how it indicates that how much you have localized your possibilities. And from that point of view, what you are expecting on examination, the patient. Right? So always mentally you should be prepared that what can be the findings. Of course, now Dr. Bhargav has given us the finding, so we can discuss on these clinical findings. I want the postgraduate. Please take one by one. You take your stand, some points, analysis, and try to come with some your ideas. Dr. Kishan. Number one, whatever he had mentioned, the vitals. Any comment of on the vitals? That means, is it normal, abnormal? Suppose abnormal, what is the abnormality?
Sir, patient has a history of fever that 99.4 degree Fahrenheit. With history of fever, there is also presence of tachycardia, sir. And that severe failure, which is on general examination, sir. So that could be finding for pointing out.
In other way, if I ask you the direct question, whether he has mentioned the severe pallor. Now my question is whether the patient is a cardiac failure or not. Who will take it? Dr. Yash, can you take it? Now you have the findings are given. Already he has mentioned the severe pallor. The question is whether is the child in cardiac failure or not.
Sir, patient was not in cardiac failure, as patient having heart rate of 140 and no edema or other dependent site edema was mentioned in history.
Yes, I think another thing I will give the tip for the exam. Always answer the question, whatever the examiner has asked.
Patient
I think question is very clear and therefore answer should be so precise. Whether from the findings already Dr. Bhargav has given to us. Now from these findings, what is your comment? Whether the patient is having the signs of cardiac failure, yes or no?
No, sir.
Okay. So number one, Dr. Bhargav, what is your idea regarding the failure?
Sir, as the child was having respiratory situation, the chest was clear. There was no significant hepatosplenomegaly was there,
okay.
And no pediatric or anything.
In other way, ask the question. In 3 months old child, suppose cardiac failure is there, what will be the signs will be present? 3 months old child I am talking. And reason for the cardiac failure may be anything, maybe the congenital heart disease, maybe the severe anemia. But what will be the signs of cardiac failure in a 3 months old child from which you can say that these are the signs of cardiac failure? Who will take?
There should be tachypnea, tachycardia.
Yes, Srishti, yes.
There should be signs of mother telling that child is taking long, deep breaths. Or she should feel the thrill when she hold the baby, like some hyperactivity cardia she should feel when she's carrying the baby. Or any signs of cyanosis she has noticed. Or whether there is difficulty in feeding, that the coordination is difficult for the baby to suck, or whether it is easily getting fatigued while feeding, or any edema she has noticed recently in the baby, or how the activity of the baby is.
Dr. Srishti, do you expect the edema in a 3 months old child?
Like dependent part we can expect if it is severe failure, sir.
Can you just explain me that what is the dependent part in 3 months old child?
So usually the sacral part we can see for the edema, or when the mother puts the baby on the same position, you can see that area to be edematous sometimes.
Whether the baby remains in the same condition for a pretty long time?
No, sir.
So that the dependent edema develops? No. So this is not the common sign. Not, I will say, edema over the feet, not even the perisacral edema, which you will not get in the 3 months old child, even in spite of the cardiac failure. So what will be the sign of the cardiac failure then? Suppose edema. How will you try to assess the edema in this baby, that this indicates this edema or collection of fluid? From which point? Anybody?
Basal crepitations.
Okay.
Then tachycardia leading to gallop rhythm.
No, regarding, I want to say edema. You know, excessive undue weight gain.
Yes.
Even what Madam said, Dr. Shaila over here, that apparently baby is not getting the failure to thrive. All other signs are showing the poor nutrition. The weight may be good, which is not, I will say, which we cannot explain. And that undue weight is a sign of the edema, collection of the fluid. Right? Of course, as Srishti and Bhargav said, even tachycardia, tachypnea, even enlarged liver will be there. Excessive weight gain will be there. You may get crepitations in the examination of the lungs, right? So these can be the signs of, but I think these signs are not there. So we can say that this our patient is not in cardiac failure. But then why the baby lethargic? How will you explain? Sleepiness. Excessive sleepiness is due to what? How will you explain? Because neurologically, Bhargav said it's not CNS normal. Am I right? Bhargav, what did you say regarding CNS?
The child was lethargic.
Okay, lethargic. But regarding the tone, power? Reflexes?
Hypotonia. The child was like that.
Then I think you should examine the patient in detail from the CNS point of view, right? You know, just if I remind you the examination, long case, there are 6 examiners and all of them are thinking differently and different questions will come. So I think mentally we should be prepared to face them, right? So that's why I'm sensitizing you. That once you said suppose hypotonia, then details examination regarding the tone, regarding the DTR, regarding the power, and then you will have to decide what is the CNS status. And suppose lethargy if you take, then how will you explain the lethargy? Lethargy due to what? Is it due to hypoglycemia? It is due to hypoxemia? It is due to the poor perfusion, right? Or it is due to some CNS problem? Lethargy is due to what? It is due to dyselectrolytemia. That can also cause this.
Anemia, sir.
Anemia, okay. I think anemia simply we can explain that, yes, baby can remain lethargic. And that is obviously because you said severe payload. So whatever we have obvious explanation we can offer. Of course, sugar already you mentioned, so hypoglycemia is excluded, right? So now from this point of view, liver and spleen, normal or abnormal in 3 months old child. Who will explain? Who will take this point? I think Dr. Lokesh was there. I want to involve everybody. If they are not volunteer, then I think probably I want to sensitize them, motivate them. Okay. I think labeling is some different. Dr. Dhairya, but he's not Dhairya. Am I right?
Yes, sir. It's Lokesh.
Dr. Lokesh. So Dr. Lokesh, can you take it? Regarding the, I think, liver, he said 3 centimeter. Am I right, Dr. Bhargav?
Yes, sir.
And spleen said 1 centimeter or just palpable?
Just palpable.
Just palpable. So how will you take it? Is it normal or abnormal?
Hepatosplenomegaly is abnormal thing.
Then what is the normal for 3 months old child?
2 centimeters.
Yeah. Then what you should go in the details. Suppose if you say size is abnormal, whether it is what details you will go ask for the liver. Was it soft in consistency or?
Regarding consistency, sir.
Yeah, consistency will give the idea.
On the margins.
Okay.
The child is having
but I think 2 centimeter and 3 centimeter is not much difference for practical interpretation. Right. So difficult to say that liver is enlarged. Right. I think 2 centimeter and 3 centimeter not much difference.
Based on the
and second thing, younger the baby, 3 months old. Right. And
which
what
is more palpable? Is left lobe or right lobe?
Okay. What is regarding the spleen?
Just palpable, but it is not able to comment exactly.
Normal or abnormal?
It's normal, sir.
Normal. Up to what age you will consider the normal? Kishan, any idea? Up to what age you can consider 1 centimeter just palpable spleen normal? Because Lokesh said it is normal. Do you agree with him or you don't agree with him?
It is normal for this age, 3 months of age.
I think for the good competition of the students, I will give the idea. Never agree with your friend. If it is right, then also. The first reaction that it is wrong. Okay, then I think after the during the dinner time, you may say, okay, you are right, but I reacted like this. And I think first reaction should be like that for good competition. Anyway, both of them are saying normal. So it's up to 3 months, in clinical examination, we consider that the spleen may be palpable without any reason. So we are not sure how much importance to be given, right? If you check the findings, so I think vitals already we consider almost within normal limits. No signs of cardiac failure. Probably hepatosplenomegaly will not be able to say, but just palpable spleen can be normal. And 2 centimeter normal, 3 centimeter abnormal, difficult to interpret, right? So now our positive findings, we have severe pallor and lethargy. I think these are the two prominent findings. And one more point, which is the one more point which I want. Positive
Knuckle,
finding.
Knuckle pigment.
Yeah, Bhargav has come with this point. In a 3-month-old child, I think hyperpigmentation of knuckle is abnormal. It's a very prominent feature. You know, you have to find out from the clinical examination very prominent feature which will give you the idea, which are not expecting probably 3-month-old child. And if it is there, Dr. Bhargav, have you taken the photograph of that?
No, sir. Actually,
The same was my problem, that they have taken now, but not taken at birth.
Yeah.
I meant to be put that, but it wasn't there.
I think now all the students, you are on the contrary expert compared to us, and you have the good facility. So always take it. Even you can discuss later on. You can this type of discussion. Even you can show them. You know, once you show it, is more convincing, and even it becomes clear to the person also. You will encourage your parents also to take the photographs, so that probably on follow-up we understand in a better way. Anyway, we consider over here that it is hyperpigmentation. So now, is there any other point? I think severe pallor, lethargy, hyperpigmentation. Liver spleen 3 centimeter, 1 centimeter, you can take in your way. Now what will be our diagnosis? What is the problem with the patient? Clinical diagnosis. Or anything is on examination? Then we'll go to the experts, both of them. They will give us these their expert comments. But before that, the students. Yeah. What is the likely possibility?
Severe pallor.
Bhargav, you should be the last person because you must have come with the preparations, and we are without preparations. Right. So I think without preparations, one should go for the discussion.
Case of severe anemia with hepatosplenomegaly.
Yes, Lokesh, I think you are speaking. Please go ahead.
In case of severe anemia with hepatosplenomegaly.
Okay, I think one side we decided that liver and spleen not important, but still if you want to take it, okay, you can take it. Then what is your diagnosis?
Anemia under investigation.
but under investigations, before that your clinical diagnosis. Investigations will plan later on. Clinical diagnosis. And no, clinical diagnosis may be, please, clinical diagnosis can be totally wrong. Okay, nutritional anemia, very good point. Now take this point, in a 3-month-old child,
with all the three parameters has been affected with knuckle pigmentation.
No, they are one by one. Because as you speak, I will have to understand. Suppose if you take the 3-month-old child, nutritional anemia, how much it is common and which variety of nutritional anemia? On the contrary, you must be aware that anyway, I think let us students speak. Who will take? Whether do you agree with Dr. Lokesh Srishti, what is your idea? He said nutritional anemia. What is your comment? 3-month-old child with this picture.
I feel this is anemia with failure, sir. Anemia with failure to thrive.
Okay.
I still feel that this baby must be in a failure, sir, because of such a clinical picture.
Srishti, my question is, can you explain on the nutritional background?
Nutritional background.
Because Lokesh wants that it is the nutritional. Now you try to explain that. Can you explain the whole story on nutritional background? And if yes, how? If not, then also why it is not there?
One is it fits into the non-organic cause of failure to thrive, sir, because of the socioeconomic history what has been given. That can add. And
in other way, how common this nutritional anemia in 3-month-old child? How common? or what is the common age for the nutritional anemia? Let us take in this way. Let us try to understand the first common. That what is the common age for the nutritional anemia in our pediatric practice? Nutritional anemia is very common, right? But what is the common age?
9 to 12.
Okay, whether the 3 months is common, probably we don't put it, right? If at all it is very uncommon for us. It's not the common age. And particularly the breastfed child, particularly the breastfed. Because you know the breastfed child, breast milk has the minimum iron, but bioavailability is very good. And therefore, usually they don't develop this nutritional or iron deficiency anemia commonly. Unless some loss or something is, that is a different story, but not the nutritional. Right. So it's not convincing in short. Lokesh, now we'll have to then go for another.
Sir, one thing that favors towards nutritional anemia is, as mother also had one transfusion 1 year back. That was when before the mother had conceived. One underlying cause is the maternal anemia that led to nutritional anemia in case of this child. And maternal nutrition status need to be assessed properly for that.
Okay. Now, I think all of you, I'm sure that being resident, you must have completed 2 or 3 years in pediatrics. And you must have seen the sufficient numbers of the patients. I think we see several mothers with anemia, but the newborns are not anemic. Am I right? You must be getting so many mothers in postnatal ward. If you see, many mothers are anemic. But the newborn or first even 1 or 2 months, 3 months, they are not anemic. And therefore, usually what we say that mother may go for severe degree of nutritional problem, but this baby parasite, that's why the parasite is usually not affected the severe degree of malnutrition. Okay, to some extent maybe in our, I would say, developing countries, but not the severe. So in spite of even suppose nutritional anemia in mother, we are not expecting the severe anemia in the newborn at 3 months as a nutritional cause. Iron deficiency I'm talking. You can modify, suppose if you want to say nutritional. Which are findings? Because findings are obvious. Anybody wants to modify it? In other way, suppose if it's not iron deficiency, which other nutritional deficiency can present? Or unfortunately it has presented probably in this patient?
B12 deficiency.
Some other, and they are known. Not so common, even again not so common in the practice. But yes, they are known. That severe B12 deficiency in the mother can be reflected in the fetus or in the baby. And early manifestations, usually on the quantity with the prolonged breastfeeding, with the severe nutritional, it is more common. Again, megaloblastic anemia, not even this age. But occasionally you may consider that, yes, it may present. I think let us now take from this discussion, Dr. Mukesh and Dr. Sheetal. Please, can you add to something more for our learning? I hope that, yes, madam. I think now findings are obvious, so you can take it from this point of view.
So I would like to add the most important finding here was the patient is anemic. So this completely rules out hemolytic anemia.
Absolutely.
So what we are left out now is an anemia which is maybe caused due to abnormal marrow malfunction. So that is either the marrow is not performing well or the marrow has shut down. So it either could be, say, going towards aplastic anemia, a pure red cell aplasia, or it could be something like as previously mentioned, maybe vitamin B12 deficiency, folate deficiency, or even in our case, we actually are seeing a lot of B12 deficiencies in early infancy also, because mothers do not have adequate stores in the first place. Absolutely. So if the mothers are deficient or mothers are pure vegetarians, we have seen children presenting with ITS or children presenting with severe anemia. So what I could think now is that the patient presently has something which is related to marrow malfunction. Either the marrow has stopped producing or marrow doesn't have enough nutrition to produce blood. So this is what I think, but it is not a hemolytic anemia as it has been conveniently ruled out by not being anemic.
I think Madam has made the very important point, and with exam, suppose by chance if you are knowing the case even, most of the time all of you are knowing. But I will say for the good discussion, we can say that something is wrong rather than hemolytic. Already she said one sentence, yes, it's not the hemolytic, any variety. Right? Not even the acquired following any malaria also, because in malaria also otherwise some tinge of jaundice is common. So then the question comes, and not even the nutritional, so common at 3 months. So something is wrong with the marrow. You should focus with the marrow. Then bone marrow in what form? Either some congenital, and that you can start from the diamond blackfan or something, or even osteopetrosis. Yes, it remains one of the possibilities. Or third, even the infiltration. And infiltration can be due to the various reasons, right? So either the bone marrow is actually not working properly, and one of them, even as already we discussed, that B12 also is one of the presentations, or even some other varieties like osteopetrosis or even infiltrated disorders, you can take it. I think here I would like to put the question in some other way to the students. Why not with the Gaucher's disease? I will say it's a Gaucher's disease. Gaucher can present in this way because liver is just enlarged, yes, spleen is possible, and even anemia is possible. So I will think it's not so common, but I think after all this considering conditions, how much it is common. I think let us get the answer from Dr. Mukesh regarding all these possibilities, starting from common to uncommon. Sir, can you include that how we should go further, please?
Right, sir. So basically, everything, if I try to summarize the database of the child, it's a 3-month-old female child with a pallor, fever, excessive sleepiness. On an examination, we have severe pallor. There is edema. There is hepatomegaly, which is of 3 centimeters. Spleen is just palpable. So, and the heart rate and the respiratory rate are on higher side. So here we have to take a call whether this hepatomegaly is because of failure or it's present. So it is a big catch here as per me, because if it's a hepatomegaly, my differentials would be totally different. And if it's a hepatomegaly because of failure, my differentials would be totally different. So if it's not an hepatomegaly, I strongly feel that this hepatomegaly is because of failure. So my differentials would be aplastic anemia, specifically inherited bone marrow failure syndrome, which can present at this age, probably evolving inherited bone marrow failure syndrome, in which there are many conditions. So this spectrum of this term inherited bone marrow failure syndrome covers many diseases. Other would be nutritional anemia, which specifically megaloblastic. But the odd point here would be they usually have small amount of jaundice, and just palpable splenomegaly is a strong pointer towards a megaloblastic anemia. Third would be an MDS, myelodysplastic syndrome. They can also present like this. Leukemia, rarely without all this, without this hepatosplenomegaly, they can rarely, a subset of it, say about 1 to 5% would present like this. And these would be my differentials. And in inherited bone marrow failure syndrome, usually the age of inherited bone marrow failure syndrome is also at around the end of the first decade, but they can present early too. So in that spectrum, the early presentations are usually seen by Diamond-Blackfan syndrome. The majority, 90% of the Diamond-Blackfan syndrome children present before 3 months of age, and another 10% presents before 12 months of age, 10%. So almost all present before 1 year of age. So but the odd point here would be a bit of splenomegaly. Splenomegaly is usually not seen in Diamond-Blackfan. It is very odd. So that is a presentation for pallor. Had this child had infection, then I would have thought of Schaumann diamond or congenital neutropenia, or this child had some bleeding manifestation, I would have thought of congenital amegakaryocytic thrombocytopenia or thrombocytopenia with abnormal radii. So I strongly feel it's an inherited bone marrow failure syndrome. And another pointer towards that is a growth failure. All the parameters of the growth are below the third standard deviation. So that's a big point. But I would like to ask the residents, you said there are no dysmorphism. I would also like to ask which dysmorphism you looked into.
Yeah.
And were there any stigmata of other stigmata of inherited bone marrow failure syndrome on examination, and which stigmata you would like to do?
By dysmorphism, we mean that in case of diamond blackthorn, the child may have abnormality in thumb anomalies would be there.
Right. Can you elaborate from head to toe which
Yeah.
all physical stigmata you would like to see in cases of inherited bone marrow failure syndrome? So, inherited bone marrow failure syndrome spectrum usually consists of Fanconi syndrome, the dyskeratosis congenita, Schaumann-Diamond, Pearson syndrome. So these
Schwann
are the
syndrome.
four most common. Right. There are more, but these are the four most common. So which all features you would like to see from head to toe? So it's not merely thumb.
Sir, sutural overriding.
Right. So it's not sutural overriding. Let me just elaborate on the points on physical examination, which you would like to see. First is the head circumference. It is, we expect it to be microcephaly in about, as the growth is hampered in about 40 to 50% of the cases. Head circumference, then in the eyes, epiphora. The ears could be deformed. They could be deformed. There could be low set ears, or it could be a atrasia of the ears. Then the face is usually beak shaped, triangular face, beak nose, and specifically in diamond blackthorn, we see a teacher colon-like syndrome, anti-mongoloid slant and all that. And in the mouth, we see a high arched palate. In the tongue, we can see leukoplakia, dental caries. And when we come down to the neck, reticular changes. And in the skin, hypo or hyperpigmentation, capsular spots, reticular skin changes. In the spine, we can have kyphospenosis. In the rib, we can have deformity evident on, if too severe, it can be evident. Then coming on to the hands, we can see that nail dystrophy.
Yeah.
Then 6 thumbs, 6 fingers. Then the thinner hypoplasia. Then coming on to the thumb, all of our favorites. It could be biphalangeal, triphalangeal. It could be hanging by. It could be totally absent. Then coming on to the pulse, the pulses are usually absent. It could be absent. Then to the gonades, very important. Gonades in the males, it could be undistended testes, it could be phimosis, it could be short phallus, it could be absent of testes. In the females, it is usually bicornate, this called uterus. And in the feet, we can see that there could be 6 fingers, there could be syndactyly, and there could be clindodactyly. So these are the few of the things which we need to see from head to toe when we are suspecting inherited bone marrow failure syndrome. So there are mixed things, but these are the common ones.
I think Dr. Mukesh, can we add this hyperkeratosis congenita and this some?
Yes, sir. Yes, sir. Yes, sir. Bilkul, sir. Right. Absolutely. In addition to that, there are many more like cartilage hair syndrome, familial marrow failure. So there are many. So these are the ones in which all lineages are involved. There could be ones in which it is still called inherited bone marrow failure syndrome with isolated cytopenias, like diamond blackthorn is included in that. Congenital dyserythropoietic anemia is included in that.
Yeah.
TAR is included in that. CAMP is included in that. So it's a spectrum of disorders. So I would feel that.
So I think sir has brought out very important point for the postgraduate, that once you say dysmorphism, yes or no, I think it is expected from us that we should be knowing the associated conditions or some syndromes, common at least. So I think that is very important. And you know that now the dysmorphism associated conditions are several. And particularly when you are thinking for the bone marrow failure, I think these are the common conditions which we should keep in mind. So I think gradually I will have to keep in mind timing also. So with this clinical discussion, I think should I request Dr. Bhargav, he must have some investigations. Again, from investigations, we learn something more details. Anything, sir, or should we go for the investigations? Okay, Bhargav, you can share your PPT with these investigations. Dr. Mukesh, before that, whether the HLH is possible in some patients? Familial
right,
HLH, what is it?
Right, so HLH is usually suspected in children when we have fever, we have significant splenomegaly. Usually it is just not a tick. And because, yes, it is possible.
Yeah,
I would
because not the secondary, but primary, I will say HLH can present at this age also.
Definitely, sir. If it is presenting before 1 year of age, we have to suspect primary HLH far more common than secondary HLH. Definitely. It is very well taken.
One more personal thing, as I think we did discuss, but literacy as a part of histiocytosis can present like this when we are talking about bone marrow infiltration or a bone marrow failure.
Right, ma'am. I had mentioned upfront that if we have to agree that whether there is hepatomegaly or not. So if it is not an hepatomegaly, I would not like to consider. Similarly, I would not like to consider this storage disorders also, because they usually present with hepatosplenomegaly.
Absolutely.
Yes, definitely.
That's why probably Gochar we may not consider. Suppose somebody is asking, you can say
all probably storage and a little too early for the storage to come with hemopoietic manifestation so early.
Right.
And even on examination, no significant organomegaly. That is a very strong point to exclude them. Okay.
So it is for the residents. Always say you can always say that these are the points in favor, though the oddities are these points. So I did not consider that strongly. Yes, but still it is a possibility. Never rule it out.
Yes.
Yeah. Uncommon are always there. Okay, go to Bhargav, starts with, because we have only half an hour left now.
Yes. On investigating, the hemoglobin was 2.7 gram per deciliter. The indices were MCV was 96 femtoliter with MCH of 35.7 picogram and MCHC of 37.4 gram per deciliter. The RDW was 17%. The child was having total count of 21,200 with 86% of lymphocytic predominance, and platelets were 1,27,000 per cubic millimeter. On peripheral smear examination, RBC morphology was severe anisopoikilocytosis was present, along with RBCs are found to be macrocytic normochromic, along with macro-ovelocytes are also seen, along with some RBCs are microcytic hypochromic also. Few teardrop cells, few fragmented RBCs, few NRBCs, and few polychromatic RBCs are also seen. WBC morphology, smudge cells and many degenerated cells are also seen. Few atypical cells showing high NC ratio and few reactive lymphocytes are also seen on peripheral examination.
Your retic count was 4%. An important point that you need to make it here.
As the child was having severe anemia and we have thought of sepsis, we have sent the CRP and also done the culture, urine culture and blood culture examination, which was also turned out to be normal in this case. And the ferritin of the patient was 283 nanogram per milliliter. Other renal function tests are normal with SGPT of 92 international unit per liter and SGPT of 215 international unit per liter. The other parameters are also investigated, like mother's blood group, which was B positive, along with the patient's blood group, which was B positive. Coombs test was also done to rule out the congenital hemolytic anemias, which was negative. Coming towards the infection portion, HIV, HBsAg, HCV, and along with the torch titer was done, which was also negative. Because our patient was belonging to the tribal areas, to rule out hemoglobinopathies, we have also done the parental HPLC, which was normal. Maternal B12 level was also done, which was on the lower sides. Inference, based on the clinical examination and investigations, CBC and peripheral smear was suggestive of anemia due to vitamin B12 deficiency. Sepsis was ruled out. Congenital hemolytic anemia was ruled out by Coombs test and parental HPLC. So there was no presence of ABO and RH incompatibility and thalassemia. Maternal vitamin B12 deficiency was present. So we have started supplementation to the mother and child. As the child was having severe anemia along with the impending congestive cardiac failure, we have given the treatment as below. 2 PCV transfusion were given. IV antibiotics and supportive management was also given. Feeding counseling and lactational support along with the B12 supplementation was started. After 2 PCV transfusion, we have repeated the hemogram of the patient, which includes HB of 9.9 milligram per deciliter with total count of 6,000 per cubic millimeter, and which suggestive of differential of 56% of neutrophilic predominance, and platelets were 2,08,000. As the child was not gaining weight, even after the above treatment, supplementary feeding and micronutrients were started. Clinically, severe pallor was present, so the investigations were repeated on the 11th day of admission. The parameters were suggestive of hemoglobin of 5.8 gram per deciliter with total count of 2,200, which was 88% of lymphocytic predominance, and platelets were 35,000 per cubic millimeter. Along with the other portion of CRP, urine culture and blood culture was negative. So on 11th day of admission, the child was having peripheral smell picture of pancytopenia, in which thus we have ruled out the sepsis. So our plan was to do bone marrow aspiration. On bone marrow aspirations, we found the bone marrow is hypocellular with erythroid series, which is markedly suppressed and shows normoblastic erythropoiesis. There was no evidence of this erythropoiesis. The myeloid series was also suppressed, and which also showed normal progressive maturations. Commenting on the other cells, the lymphocytes were 35% with predominantly involving the reactive with few large activative lymphocytes also seen. Blast cells are within normal range. So inference of bone marrow aspiration was hypoplastic marrow with trilineage suppression of hematopoiesis. There is no evidence of leukemia in the smear received. These are the bone marrow aspiration slide. The first portion on the left side shows the reactive lymphocytes, and on the other two slide also shows reactive lymphocytes, and the third slide also shows hypocellular bone marrow, which is present in our patient. So based on our bone marrow aspiration findings, the marrow was hypocellular. So as Mukesh sir has told, to rule out inherited pancytopenias, some conditions like Sperman Diamond syndrome, Fanconi's anemia, congenital amegakaryocytic thrombocytopenia, and dyskeratosis congenita was thought. But our patient's age is not fitting into all 4 diseases considered as inherited pancytopenias, and the age of presentation is also not fitting into our patient's situation. So these were ruled out, sir. Coming towards the storage diseases which are associated with the pancytopenia, the first one is the Gaucher's disease and Niemann-Pick disease. Gaucher's disease has hepatosplenomegaly, and in type 2 Gaucher's disease, there is variable involvement of neurological portion. In Gaucher's disease, there is raised liver function test, and in bone marrow aspiration, we can found the Gaucher cells, which in our patient, we could not found. So we have also ruled out the Gaucher's disease. Coming to the Niemann-Pick disease, which can have presentation in infancy to adulthood and can present in infancy. Liver function wise, there is raised LFTs and high lipids, but in our patients, their lipid profile was normal. And in Niemann-Pick disease, there will be presence of foam cells. As in our case, there were no such cells present. So coming towards the course during the hospital, on the first day, the picture was severe anemia with hemoglobin of 2.7 with total count of 21,000 and platelet count of 1,27,000 with 86% of the lymphocyte predominance. On receiving, the liver was 3 centimeter palpable and spleen was just palpable. Considering severe anemia, we have transfused 2 PCV to the child and repeated hemogram on the 6th day of admission, which was showing hemoglobin of 9.9 along with the total count of 6,000 and platelet count of 2,08,000. As the child was having poor weight gain and the child was having a severe pallor, we have again repeated the hemogram on 11th day of admission, which was showing a picture like pancytopenia. So we have done the bone marrow aspiration, and before doing bone marrow aspiration, we have transfused 1 PCV to the child. On 14th day of admission, we have done our procedure bone marrow aspiration, and a bone marrow aspiration was suggestive of hypocellular marrow with reactive lymphocytes, which was leading us to the probable etiologies of sepsis, vitamin B12 deficiency, leukemias, aplastic anemias, and viral infections. From our investigations, we have ruled out sepsis as blood culture, urine culture, and CRP. All the things were negative. B12 deficiency was kept in mind as mother was also having low B12 levels, and leukemia, aplastic anemia we cannot found because in bone marrow we could not found any blast cells, and also viral infections. Coming towards a viral infection, Storch titer we have done, so which was ruled out. HIV also we have performed, so which was also ruled out, and two more infections which are more common and leading to pancytopenias like Epstein-Barr virus and parvovirus are kept in mind, but we have not yet investigated for this virus. So flow cytometry of the peripheral blood was also done, which was normal. Torch titer was also negative. Congenital anemia is also ruled out as per above discussion, and HIV was also negative. So summarizing the case, 3-month-old female child with severe anemia with hepatosplenomegaly with pancytopenia due to vitamin B12 deficiency we have kept in our mind.
Okay.
After, I think you can just continue.
You
further
can
here because this is not complete.
You can finish it.
Further.
Okay.
You can finish it.
Okay. After 2 weeks, we found that the hepatosplenomegaly was again increased. Liver was 4 centimeter palpable below the costal margin, which was soft in consistency, smooth surface and rounded edge, and spleen was 3 centimeter palpable below the subcostal margin, which was previously just palpable, which was normal for age. So we thought of repeating the investigations again, and on repeating the investigation on 36th day of admission, we found out that the child was having HB of 5.8 gram percentage with total count of 37,520 with 68 percentage of lymphocytic predominant with platelet count not decreased, but it is consistent with 1,20,000 with retic count of 17.4 percentage and RDW of 71.2 femtoliter. Peripheral smear examination was showing late normoblast 12% with anisocytosis, absolute lymphocytosis, and mild eosinophilia was there. As the bone marrow aspiration has presence of reactive atypical lymphocytosis with hepatosplenomegaly, we have done Epstein-Barr virus viral capsid antigen IgM levels of the child, which were turned out to be positive with a value of 18.07 unit per milliliter. So we have kept our final diagnosis as pancytopenia, which can be due to vitamin B12 deficiency with Epstein-Barr virus as a co-infection in a case of failure to thrive.
Okay. Can you just stop sharing? I think to save the time, let us take the experts for our learning. Dr. Mukesh, can you take it first that what is your view from all the investigations? How would you take it?
Right, sir.
Because otherwise I must have started from the peripheral smear, but now we have the less time. Otherwise, I will start that the interpretation of the smear is very important for our learning. And then even whatever the condition is different. But I think now we have not much time, so you can probably take your I will say interpretation that how you are looking at this scenario.
Right, sir. So basically, just to mention a few points before I take up how I interpret it, just for the residents learning, he had mentioned in one of the slides that congenital hemolytic anemia have been ruled out by DCT and ICT. So congenital hemolytic anemia is never ruled out by these DCT and ICT. These are the immune hemolytic anemia that are ruled out. And that too in about 5 to 10% of the cases, these DCT and ICT may be negative. So even if it is an immune hemolytic anemia, we can never rule out immune hemolytic anemia. Congenital hemolytic anemias are never ruled out. Right. So overall, a well-managed case, interesting case. I'm still perplexed what exactly I'm not very sure with the diagnosis till now. I'm not really convinced. So basically, as the child was not having liver spleen initially, now he's having liver spleen. So we would have to start refreshed from the very point again, that we have to work up him again. Regarding in the workup, I would like to see the bone marrow biopsy also, because aspiration alone is not sufficient. In the bone marrow biopsy, we see the architect, we see the quantification of the cellularity, which is a very important aspect of any aplastic or inherited bone marrow failure syndrome. So this, and now if he has Epstein-Barr virus, Epstein-Barr viruses usually cause pancytopenia without hepatosplenomegaly. So merely having a raised title, I'm not sure what exactly we are dealing with. This case needs to be worked up thoroughly again.
Okay, we do have a follow-up of today's his hemogram and his current status. But definitely your opinion of that we should look at the biopsy or have a constant follow-up is, yes, very much.
Really important, because Epstein-Barr viruses usually cause cytopenias, but they don't cause hepatosplenomegaly. That usually cause, but they don't cause.
Maybe
So
we, kind of have given multiple transfusions. We've given over a period of 4 weeks, child has received 3 to 4 transfusions.
Right, ma'am. So that was at how many mLs per kg each transfusion?
15 ml per kg. PCV.
15 ml per kg to 15 से 3 adequately rise है, that should not lead to hepatosplenomegaly, क्योंकि rise to
No, but actually that is the point worried us. The counts changed and the hepatosplenomegaly increased was a point of worry for us also. When we started.
Another important point I strongly feel in this case is, if we see his CBC sequentially, in all majority of the CBCs, lymphocytic predominance is there.
Yes,
and counts are on a rising trend now. It's not pancytopenia. And hepatosplenomegaly has also manifested fully in the later slides. So leukemia could still be a strong possibility. Usually this is a common, not an uncommon scenario to see the body immunity takes over the leukemia, and ultimately the leukemia take over the body immunity and it manifests fully. So it could still be an infected leukemia. It could still be inherited bone marrow failure seems unlikely now after manifestation of hepatitis.
Dr. Mukesh.
Overall, probably today's hemogram and the clinical picture of the baby also I'll ask him to post. But definitely, fortunately, this child was very low on weight and has been on follow-up at least now is almost more than 6 weeks that we've been seeing this child. But as you said, this has been our worry also about this. And it is really, yes, as you say, we also thought Epstein-Barr is uncommon in first 3 months really to present like that. But because it came positive and the atypical lymphocytes and the lymphocytosis was something guiding us that we should keep that as a possibility.
Definitely, because Epstein-Barr viruses are known to cause immune anemia and immune thrombocytopenia, but our here DCT and ICT are negative. So they are very much Epstein-Barr virus is typical to cause it, but the odd would be that our DCTs are negative. The odd would be that. Have you recently done DCT also, or it was just done in the prior admission?
No, that was earlier, but probably we could repeat as you are pointing. We have just done a recent hemogram, which is definitely now there is no immune hemolysis. The hemoglobin is stabilized and improving. Child is thriving well, has gained 1.3 kg over a period of 6 weeks. And growth as well as the development of the child has quite managed. For child has not been febrile with us all this during the period. And,
I would say but the bone marrow aspiration and biopsy at this point probably would give an answer.
Dr. Mukesh, 2 or 3 questions regarding, I will say, the post-graduation for our learning. I think in this case, it's a different story. Number 1, for the diagnosis of megaloblastic anemia, how the B12 assessment should be reliable, or what are the other tests which you will advocate?
Sir, it's like for the B12 deficiency, usually it's
because most of the hematologists say that B12 assessment or the may not be the, I will say, very reliable test for diagnosis of the B12 deficiency. They said either you should go for homocysteine or methyl malonic acid. So what is your stand?
Right, sir. Basically, first thing that we have to suspect. First thing is that we have to suspect. Then the peripheral picture, the other cell lines being low, clearly the child having pallor, small amount of evictus, some spleen test, then the high MCV, definitely in this investigation, MCV, pancytopenia, and then yes, B12 and folic acid, and the B12 and folic acid levels are not altered by blood transfusion. So even if the child is transfused, we can get the B12 and folic acid level. They will not be altered. It is mentioned in all textbooks classically. So transfusion should not defer us from getting these evaluation. And homocysteine level, as you mentioned, are definitely better than B12 and folic acid level per se.
Dr. Sheetal, regarding the diagnosis of Epstein-Barr virus, which test you would like to consider the better? Is it the PCR or this IgM to the capsid will do?
Right, sir. So, sir, at this age, at 3 months of age, it is very unlikely to get...
I think regarding this case, we are not sure whatever it is. This is for our general learning.
Right, sir. So, for a very small infant, like for this, you should suspect a congenital EBV or a primary immunodeficiency which has caused EBV. So, here I would have gone for a PCR here in this case to actually definitely point out whether this, whatever lymphoproliferation or whatever has occurred is due to EBV or not. First thing. Second thing would be in an adolescent, maybe a child who has come with lymph nodes, hepatosplenomegaly, not major hepatosplenomegaly, and lymphocytosis on blood smears showing activated lymphocytes. Maybe in that case, I would go for a viral capsid antigen IgM to look for infectious mononucleosis. That is an acute EBV which has caused. The second thing which I would like to know, if this EBV is a reason, then I would like to go for a repeat bone marrow and look for primary immunodeficiency in this patient. So I'd like to follow him up, see the growth pattern, see for infection pattern if it only develops again. And the third thing would be to repeat biopsy again. And fourth thing would to go for immunoglobulin levels, etc. Look why this actually, if EBV, if IgM is positive, that might be significant, even though I don't think the titer is very high. But if it is there, then we should rule out immunodeficiency also.
I think what is my question to both the experts? My question to both the experts.
I want to tell something.
What is your question, Ashwati?
Sir, actually, congenital immunodeficiency is also one of our differential diagnoses. We were also thinking of ALPS, congenital lymphoproliferative disorder. And for that, we also did this lymphocyte subset analysis, and that is normal. We didn't do immunoglobulin level as a child's age is only 4 months, but lymphocyte subset analysis is normal with lymphocytosis and cytotoxic T cell increased. So there are few case reports are there. In EBV, this hyperstimulation of cytotoxic T cell may suppress the bone marrow. So initial bone marrow suppression might be because of this B12 deficiency along with this cytokines, and after treating B12 deficiency and recovery from the infection, it is improved. Now his hemoglobin is also not dropping down.
Right.
So cells are also normal.
Okay.
I think,
so right, so relevant investigations were done.
I think
EBV.
Okay, madam, continue.
So EBV is an atypical infection which shouldn't occur in this age group. So if an atypical infection occurs, then the pointers should for immunodeficiency. So this patient actually should be followed up again at 6 months. Again, the investigation should be repeated to look for other causes. And this cytotoxic T, again, I think the lymphocyte analysis should be done again at 6 months to go for definitive analysis. As you said, 3 to 4 months is a very dicey age to diagnose anything, because of the immature immune system at present. So I think investigation should be repeated again at 6 months.
I think again I want these expert comments from both of you. I think as a general pediatrician, what would be my thought process? That basic regarding this hematological problem, apart from that, child is not thriving. Failure to thrive is the basic issue. I think most of other conditions, if you go through either nutritional or something, hematological condition, nutrition will not be, I would say, thriving the baby will not be the common presentation. It may be to some extent, but not this very prominent. Here, failure to thrive is also equally important. I will say basic issue along with this hematological condition. Suppose if you put together, I think most of the points already we have discussed, and now we have the evidence, some of the investigations also, that probably nutritional is not much convincing, except this B12 if at all we consider, okay. Second, already probably both the experts, they said that the primary bone marrow failure, except unless you go probably the bone marrow biopsy, difficult to make the comment, but whatever is available from that failure is not the evident. Then if you go for this further analysis, that which factor is not allowing the child to go for thrive. And then I think if you go for that reason, I think important two components which we may come across, one is the immunodeficiency, which already have been thought of. And second, is there any metabolic disorder, inborn error of metabolism, which even does that the not allowing the child to thrive, as well as even this type of the hematological derangement, which we can keep in mind. I think first the comments from the experts regarding that, or whatever, Dr.
Just
Shaila,
to give you
whatever your
feedback
thought
further.
is. Yes.
Feedback further. Yes, failure to thrive was an important aspect, but over the period of last 5.5 to 6 weeks, the child has thrived well with proper nutrition and feed aspects taken care with all micronutrients.
What is the weight
gain? The child has put on 1.3. Current weight is 1.3 kg plus. So it's 4.4, na?
4.0
and
kg.
hemogram also, I think he can post the current anthropometry as well as the hemogram. So during the current follow-up, there is definitely recovery as far as.
Okay. I think just we can keep in mind. We can keep in mind. But suppose may not be in these patients or something. But Dr. Mukesh, can you give the thoughts for the immunodeficiency and metabolic disorder in these are the presentations? Just for our learning.
Right, sir. Basically, definitely immunodeficiency has to be considered, specifically HIV, parental, the mother's HIV test should definitely be done. Another immunodeficiency can also present. Metabolic disorders usually do not present with so much of hepatosplenomegaly, sir. Usually they are without hepatosplenomegaly with failure to thrive. The ones which cause because now the child is having hepatosplenomegaly, initially we considered the differentials when it was without hepatosplenomegaly. So our differentials are now evolving into something else. So we have to think in toto. So now differentials would be different, basically, and it is not uncommon to see such a scenario. The child behaves differently at point. As I mentioned in child also, he may be non-transfusion dependent today, but he may be transfusion dependent later. Similarly, he has evolved into a different picture. We have to think more. We have to evaluate him more. But these metabolic usually do not present with hepatosplenomegaly. Yes, everything is possible.
Right. Okay, I think now it's a time for us to end over here. Before we probably,
I think he can post the last current reports. He can just share screen for them.
Before we conclude, I think any comments or questions from the postgraduate. First, I think postgraduates are more important. I think your questions. You can ask any question which probably has come to your mind. Anybody? And I probably motivate the students, always ask the questions. The teacher should be afraid of you. That I don't know what question will come. I think the daily round, I tell my students that teachers should find the difficulty in taking the round with the certain students. Come with these preparations. Right. So here I think we have the two experts. You can ask any question related to this topic or even probably in hematology. We have 2-3 minutes. This is my attempt to motivate the students. Unless we speak, unless we ask, unless we make some comments, we cannot learn. And here you can see that ultimately both the experts are also committing the point that we are not sure what is the diagnosis. So I think then when the experts are telling in this way, then students should not hesitate. You can ask any question, right? When experts are, I would say, confessing in this way, then students can speak anything. So please. Anyway, at least I motivate the student that next time I see that the students from the Baroda Medical College are always brilliant in the various fields. And I wish that every time, one by one, even you can participate in every clinic, whether it is Tuesday clinic, Thursday clinic of America, sir, or even this our Saturday clinic. But I'm sure, and this will be the only best learning for all of us. We can see that how many points or comments we learn from the experts also, which may not be to our knowledge or information. And I'm sure in the exam, suppose if these type of cases are there, at least cases they are keeping that what you are discussing. They are not interested for the diagnosis, but how you are putting forward your ways or thoughts. So I think in that way, before we conclude, any comments from the students and the teachers and the experts, and then we'll close this session. Dr. Lokesh, Dr. Yash, any question?
Sir, one question from my side, sir.
Yes.
So can the child may have transfusion-related Epstein-Barr virus infection, sir? Because initial peripheral smear doesn't show any significance initially, which is suggestive of B12 deficiency.
I think Dr. Mukesh Shakli's question is good. And it is said that any question is not wrong, and only answer is always incomplete. So whatever the answer, let us get the answer from Dr. Mukesh, because he said that the Epstein-Barr virus came later on in the picture, and before that we are given some transfusion. So is it possible?
Yeah, we cannot rule it out. So
we did debate on that actually.
So Epstein-Barr virus can definitely explain everything, but not a typical picture. So Epstein-Barr virus, as I was mentioning, there is lymphocytic predominance in all the series. Epstein-Barr virus can explain that, no doubt. Usually it causes hepatosplenomegaly. It causes hepatosplenomegaly. So now he has hepatosplenomegaly lymphocytic. Yes, it can explain. But we can give a trial of therapy with acyclovir or maybe to sick bread. So we can give a trial and see the response. So it is very much possible that it is an Epstein, right? Absolutely, point well taken.
I would just say today's his hemoglobin is 9.6. His counts are 13,500. His platelets are 4,51,000. And as I told you, the child is now thriving well. That child has put on over a period of 6 weeks 1.3 kg.
Right.
So and the counts and MCV now is 80 on today's hemogram reports.
So I think
with lymphocytes in his WBC count now are 58%.
58%. They are also normalized, right?
Last slide, probably you can. And like that is his growth curve. And this is the child now. But probably put the last slide of your today's hemogram, you might not have put there.
Yeah, today's hemogram he has put it.
Right. So the LCV is also in the normal range now. It's not increased.
Yeah.
Right.
And as I told you, the baby looks now very playful, active, alert, compared to what when the child came. And now the hemoglobin has also got stabilized. We haven't given acyclovir, to tell you the truth, because for young infant we were in doubt, and as the child started thriving well and things
right. That makes sense. That makes sense. If the child is improving, we need not give them. It's like definitely it makes sense.
Now, and bringing up this case with these experts was some of these things also, because we also went through a lot of this while evaluating that what are we dealing with, are we right, wrong? It always came to us as a part of question when we were.
It is rightly managed, and as the things evolve, we also evolve with the child and evaluate appropriately and whatever comes in.
But probably, yes, your suggestion is right. We should follow it up, look at his both ways, growth and hematologically, and maybe a biopsy. I mean, biopsy should be repeated if we are not really.
If needed. Right.
Maybe we can do it after 3 months, keeping him in regular follow-up.
Right.
Dr. Parker, can you stop sharing? Okay. So I think we end over here. Thank you very much. First, let me appreciate Dr. Bhargav for, I would say, good selection of the case. and your presentation was really very good. As I will say, postgraduate, it's always difficult to prepare even the proper presentation also. And I will appreciate all other students on the screen. They reacted very nicely, had the good, I will say, interactions. And of course, their mentor, Dr. Ashruti and Dr. Shaila, both of them. I think students are most fortunate that you are getting all these type of the uh, academic exercise daily in your rounds. And I know both of them, I will say, very good case even selection, madam. Your inputs even, I will say, totally work out the case is also absolutely learning. And I think in the long-term follow-up, we learn exactly that what happened to the child. Probably maybe the good if you give us the follow-up in the future after some time or so. And even Dr. Nihal and office bearers of Gujarat State Branch for providing us this platform for learning. And both the experts, Dr. Mukesh and Dr. Sheetal, we know that how it starts from the common thinking. I think that is very important for the students. We'll have to learn from them. Start from the common conditions. Go for the clinically. Put in a proper format. Go for analysis. And then investigations or bone marrow. I think not directly jump for something. And I think ultimately it always pay a lot. So thank you very much, Dr. Mukesh and Dr. Sheetal, for our inputs and I would say best points for us in our learning. And even these is a platform which provided by our Gujarat State Branch President and Secretary, Dr. Rakesh Desai and Dr. Kirit Sisodia and the whole team. Thank you very much. I end over here and over to Dr. Nehal and your team.
Thank you, sir. There was one question from other platform that severe malnutrition under 6 months with anemia, it can be a late onset hemorrhagic disease or query septicemia. I think this has been discussed very well with everything. So I thank everybody, especially both the expert Sheila ma'am and the participants. Bhargav has managed so many participants and we actually enjoyed thorough participation. Yeah. And one or two students.
Madam, I think before we end, this is my request to Dr. Shaila and Dr. Ashruti that see your postgraduates are participating. At least if everybody is not free by turn, 1 or 2 students every time. Please.
Actually, students do join on the Clinic platform, but they are not here with the faculty link. Though that this time I shared faculty link with multiple students. Otherwise, students are there on the other platform, either Clinic or on the YouTube.
I think Dr. Nehal, you share this faculty link freely to the students. I think some of your faculties are less, no problem, but the students should be more.
Yeah, sure, sir.
Yeah. Thank you.
Thank you so much, Dhankar sir and Ashruti and Dr. Sheetal Kulkarni and Sheila Iyer madam and everybody, all the students. Thank you so much.
Thank you.
Deblina, we can close the session now.